I'll try to do some of the questions in English so Heather understand them also, but it's okay to ask questions in Swedish also. So we have some here when you get brain blocked and don't have any oral questions, but let's start with the ones that you're sitting on. Any hands? Yes.
I was wondering something about the numbers here of archetypes. In Norway, you had published 27 archetypes, and in Europe, 43. But in the beginning, you said something about 2,000 archetypes was needed for a hospital. So won't that take a very long time to get there?
Okay, so will it take long time to go from some to many archetypes? I'll put the mic over here somewhere.
See, I thought those numbers were actually encouraging, only 2,000. Because when you think about it, and I don't mean it like that, I hate when people say that to me, because you are thinking about it. If you consider it in the frame of mind that the core things are core to everybody. So people say to me, where are the mental health archetypes? Where are the orthopedic archetypes? Where are all of these brands, if you like, all the different flavours of medicine that we have? And I say, well, we've got the adverse reaction, we've got the problem diagnosis, we've got all of these things that all of these groups need. And then what's happened, well, that's what we're working on as the core group at the moment. So once we have those, that is a phenomenal piece of work to get out of the way, because they are the core ones that everyone has an opinion of. So if we can get concordance on that, that is a massive thing that we've just achieved as far as being able to share health information. Don't underestimate that. And to me, then, the others are going to be relatively easy, because they're only small groups of interest who'll be wanting to do it. We don't have to herd thousands of cats and get everybody doing the same thing, you know, going in the same direction. It's orders of magnitude more simple, but it will take time. And at the moment, this work is happening in a fairly fragmented way, in that it depends who puts their hand up and say, I want to be involved. So we now have some orthopaedic surgeons who want to be involved. I've been working with a hearing program, so we have things around the ENT and the ear examination and testing side of things. We've done some antenatal work. So we have archetypes in those areas because that need has driven the archetypes to be developed. But every time we do a project, I'm finding that about 75 to 80% of the archetypes I need have already been developed and are stable enough for immediate reuse. And then we have to build, or we have to perhaps add to requirements for another 10% or something, and then maybe 10% that we have to build from scratch. And when we build the new 10%, then they go into the pool for the next project. And so in actual fact, I think we can accelerate. And I think that's what you'll see. So while the numbers seem relatively small, they're powerful ones that we're doing to begin with. And the things that the neurosurgeon will need, you know, at the point of diathermy or something, some obscure thing, there'll only be a few people who'll need it, and it doesn't matter that will come slower and at a later point. Does that make sense? It's a very pragmatic approach. So in fact, I don't feel overwhelmed by this. I am just, you know, the fact that we don't have to have, was it 102,000 archetypes for diagnosis is absolutely, you know, a revelation, so that we can actually have, you know, a few archetypes for these core things, and we use terminology to leverage all of those SNOMED terms. That's a really powerful paradigm.
So I just want to ask the question back to you there. How many templates do you have in your electronic health record systems, and how long did it take to develop those? So there are this work is being done and has been done right now in all counties without too much cooperation. So these numbers might seem small, but in the early stages when Cosmic was introduced in Östergötland, there were probably like that number of templates for a very long time.
Okay, so that's some answers. But it's a good question. And of course, there are more archetypes than the published ones. I mean, we've got some 100 ones that are like today. people have done little things here and there. You have entire hospitals in Slovenia running completely on Archetype, so they fixed everything they need, but with local things and reusing some international. So, any other questions here from the audience right now? As well.
So we had a demonstration of how you would fill in, how the clinician would fill in a openEHR template. Are there any examples today of an EHR where you could see how would that information of the template be, the already documented information, how would that be read?
In the running systems, yes, there are. You can add things to. So there are EHR systems built on openEHR, and then you have the entry form and you have the reading forms and things like that. So we're going to do some experiments with that here in Linköping now around Christmas and afterwards for the emergency department, just to get to see what it could look like. We don't know for ourselves really what it looks like, so we'll try to have a look at it. But we've seen running systems, yes, so there are those, definitely. Do you want to add something, any of you?
I was in Ljubljana in January last year seeing the Moran system, so effectively a competitor of my company with products, but they were using the archetypes that we'd helped develop collaboratively. So this is a system that's running in the paediatric intensive care at the hospital in Ljubljana. So there's one system that was actually working. My company also has an infection control system that's running across, I think it's 60 public hospitals in Queensland and Northern Territory in Northern Australia. So it's infection control systems. It's managing laboratory reports coming in from HL7 messages that say that there is an organism that is of danger to patients, and then they put in care plans about how they would manage that infection by isolating patients and so on. So that's running in real time, reporting as a single unit. So while it's installed in multiple hospitals, it's reporting back to government with one whole report and so on. There's regional organisations that are using care planning systems with distributed clinicians in different practices contributing to one central care plan for the patient. So physiotherapists are in their office, the GP is over in another suburb somewhere and so on. So they're quite sophisticated systems running live on these kinds of things. So there are other vendors that are out there that are also doing it, but to degrees that I'm not privy to, and how broadly distributed that is, I don't know. But yes, it's absolutely working and it is gathering momentum.
And another way to look at it is that you probably won't see much of a difference between a system using archetypes and not using archetypes as a clinician. You might see it during development when someone asks you, what do you want it? How do you want your model? And then you sit the model in this strange tool, whatever, and then they push a button, and then you can see it could look like this, an entry form. So you get to see that a lot earlier than you see in other cases, and then we could import it straight into the system.
And you will also see it once you ask to get your data back, which will a lot of the time be a lot easier in an openEHR-based system than in other systems.
I think this is actually something that's important. We should not be showing this to our clinicians. They should not necessarily understand that there is openEHR sitting underneath it. While they may help devise the data structures and so on, the user interface and everything else should not show archetypes at all. It should be showing them the data that they need in the context they need, with the workflow that they need, etc. So the majority of clinicians using an openEHR system will not have a clue that that's actually sitting underneath it. It should just be a good system. And I think that's a really important thing. This is a kind of philosophical approach, and it's about strategy, and it's about getting quality data out for reports and so on. But for the average end user, they will be oblivious to this.
I think it's the same with Snomed CT, that you probably won't see on the surface that a Snomed CT inside. But what you might see with this, with archetypes and stuff, is that your changes go faster. You don't have to wait so long if you've been able to have this fight with your peer clinicians all over the world about what are we going to catch in this kind of archetype, then we can very fast take it down. If nobody's done that job, then someone will need to do it, and it takes time. Any other questions from the audience right now? That's good.
Much of the discussion here is about archetypes, but the way you presented it, Heather, especially in the beginning, is really that it's template modeling which should concern most clinicians, and where the majority, I think, of the work will be done eventually. And now it exists in many countries and contexts also, I think, that people are modeling templates which have not been part of the international sort of community. And also in Norway, you were only talking about archetypes. So my question is to the panel, how do you see the template involvement? Because that's, I think, where you will also have the fast development, as you demonstrated, Heather.
We are focusing on the archetypes mostly in a national level in Norway at the moment, because you do need the archetypes to be able to build templates. And we do want them to use published archetypes so that they don't create a template and then have to do it again next week because the archetype changed. As long as we have common stable archetypes, templates should generally be made by the people who are actually going to use the data, so that they actually get the data that they want to input into the system and the data that they want to get out of the system in the correct way, the way they want to do it. Except, of course, in the situations where you want to specify, for instance, a message or a quality registry data schema, for instance, that those could be national templates. But again, we do need the archetypes to be able to make them.
I think it has been mentioned today that Ian McNichol, who's based in the UK, has a famous saying now, because we say it a few times, and he says that archetypes get all the glory, but templates do all the work. And that's the reality of what you're just saying. The focus of a lot of the discussion today is about archetypes as that foundation. But the truth is that the templates are where I think the majority of people here will have experience. To be able to take, or to build an archetype from scratch, maybe, but to actually take one that's been built perhaps as a demonstration for a discharge summary or some key document, and tweak it to your own local use with minimal training in a distributed way that everybody in the regions, the organisations, the hospitals can actually start to fine-tune these templates, I think is a very powerful paradigm for how we can start to get health IT working. I think trying to build a template will show tomorrow, and the focus of the hands-on workshops tomorrow is actually more on templates than it is on archetypes for that very reason. We want people to walk away with some sense of skill and competence and confidence that they can actually start to put some of these templates together. But I'd say to all the national programs when I'm talking to them, it's actually a small core group of people who will manage and govern the archetypes. They're the ones who need to be super skilled to be able to make that cohesive pool of effectively a national standard for clinical content. But we can get everybody building templates in a distributed manner, and I think that will actually fast-track all of this. So templates will be doing all the work in that effect once we get those foundational archetypes in place.
But I guess reviewing archetypes is something that a lot of people will be involved in.
Absolutely.
So building it could be tricky, but being a reviewer with your clinical needs is something that a lot of people can do. More questions from the audience? Yes.
My name is Göran Karlström from Värmland, and I'm the head of object owners for Sweden. And we are talking about future directions on care documentation. One of the main problems we are having in Sweden when it comes to automatic deployment of data to quality registries are that they have to be Snomed CT matched. That's a common language between the quality registries and the EHR systems. And a lot of things in the quality registries need several Snomed CT codes. They need to be post-coordinated. Can we use the archetypes to solve that for us? For example, we had this eye examination. So if there's one Snomed CT code for eye examination, and one for the left eye, for left, so to say, or different anatomical structures, and you would like to combine these codes. Could that be done in the Archetype way?
While I'm walking back, I think you could do it also in the template, the terminology binding. So you have two choices, either in the Archetype, if it's something globally, or in the templates. But I'll leave it to the experts.
I definitely agree with Eric on this. You would normally do the terminology binding of the value sets in the templates and not in the archetypes for several different reasons. But yes, you could use templates as a way to control post-coordination, because post-coordinations, as many of you probably know, can be quite tricky and can lead to unexpected results if you don't control it well enough. But if you select the different small value sets that you want the clinician to be able to combine into a post-coordinated expression for the registry, then you can use the template to control how these, or what these small value sets are and how they fit together. Of course, the final post-coordination into a Snomed CT expression using that syntax would have to be done by the software, but the data entry can definitely be controlled in the template.
So first, me and Mikael made a demonstration of what you were looking for in 2012 for when the Snomed CT conference was in Stockholm. So we made a very small demonstration to show that you could build answer the queries from a quality register by querying for Snomed encoded archetypes. So that's something that's definitely possible, and we also showed that to the NPDE project. And I think they're using the nationell informationsstruktur instead of this archetype framework. So that is of course a difference. But basically they have this aim, and whether they're achieving that or not, that I think is to be seen. But I realize this is an issue. Having the questions in the quality register are often quite complex and not well suited for single Snomed CT codes.
Using information model can, of course, be seen as a kind of post-coordination. It is a real thin border between them. And I think those cases where you need to post-coordinate some things, it is a good idea to use archetypes instead. But you can also use Snomed CT and ask queries down to the information models. For example, for those cases where you would like to document much more fine granular in your information model using Snomed CT than what you would like to store into your register.
And for those of you that have been sitting on post-coordination, what is that? Did you mention that a little bit earlier? No, it's actually when you have Snomed CT with all these branches and details, you could, even though there's 300,000 concepts, that's not enough for covering medicine, because you don't model this for the left hand and this for the right hand things. You can instead combine, okay, this is the disease or finding or whatever, and then you add right or left. That's a post-coordination. You're doing it afterwards, not when you're designing Snomed CT, but when you're entering data. So that's, if you have a weak model where you can only put in one value or something, then you really need to use this post-coordination, because we need to say everything in that little value thing. If you have a little bit richer model with several little, like a little tree of things, then you can say some things here, you can say left there, and you can say the finding there. So there are different ways of doing those things. Okay, so that's post-coordination.
I just add one comment that what we need to make sure is that each of the components for the post-coordination needs to be in the archetype, so it needs to be part of the archetype review as well. So this is where, even in this situation, we have to make sure that that base model would have all of those appropriate components. So we've got that assumption, but often it is things quite simple, as in sort of combining a diagnosis with an anatomical location and some other qualifiers and things that are already in existence. But that's why all of these groups, we need to talk to all of the range of clinicians, all of the range of organisations who are doing reporting and so on to make sure their requirements are also in the archetypes. It's not just the clinicians alone, it's about all of the other uses we have for data.
Okay.
And in one way to use the information model to express the complexity might just move the complexity of post-coordinating expressions into the complexity of modeling the information model instead. And that is not necessarily easier. At least, for example, if you work in Snomed CT or other terminology systems, you have a concept model behind that you need to fulfill. And in some other information models, you don't have any concept model at all, so then you can do really, really crazy things instead.
And I think we will see more of that, having archetypes looking more at Snomed CT, for example. Earlier it was a bit difficult to know if you didn't have a Snomed CT license, could you use the structure from Snomed CT in an international archetype? And now it seems like, yes, you can do that, but don't send these little number codes to those that don't have their license. And then we could actually, if there is something that is really good, well modeled in Snomed CT, instead of inventing something else that would work, we could probably pick that. So we will see more of a convergence, I believe, now when some of those issues have been solved, and also when the quality of Snomed CT is rising piece by piece. But that also takes some time. So we need to have something that works now. That's what you say when it comes to Snomed CT bindings often. Something that works now for real, even if Snomed is not there yet. And then you see a lot of improvement happening in Snomed, and some pieces that are really great that you could use. Any comments on that?
I was just thinking at the same time as you're saying that, I've actually got an international hat on. So while you're using Snomed and we're going to leverage the power of Snomed, I'm also conscious that all of the archetypes that we develop in the international space need to be usable in the international space. And there's a lot of countries that don't have Snomed licenses. They don't have any formal terminologies. And if you think about use in Africa or with openMRS and these other products that are being used in these situations, we need to have them so that we do have information models that cover all of that data as well. So again, there's the sweet spot, I think, that we need to spend some time investigating about how best to use these things. But the information models will always try to be as fairly comprehensive, even if not necessarily we would choose to use it when we have Snomed as well.
Okay. Any other questions that have popped up? We have got some written questions here. Yeah, there's a related one here. Are there any plans to place Snomed CT codes massively, like close to 100%, into archetypes? And this, I think you could start and then Heather could go on.
So probably not. As at least I tried to show before, the scope of Snomed is slightly different from the scope of archetypes, and there will be things which are not easily expressed using Snomed. And there is really, unless you have some relationship between the elements of an archetype, if there's something that is only used in one place in one archetype, there is perhaps no need to, there is no benefit in adding that to, adding a Snomed code to that as well. There is, so probably that could be more than now, but probably never 100%, I guess.
It's interesting, but I think that we have our own backgrounds where we come from. So I am very focused on the information model and how best to use that. And I know that a lot of Snomed people are very biased towards Snomed and would prefer to use the power of that. So I've been aware that for a long time we need to have a conversation between the terminology people and the information modelling people. And the grey zone has been recognised for 8 or 10 years, but I think this is probably the first time I've been involved in a conversation about it. And I think probably the people sitting in this room here at the moment are the people who have most knowledge about the combination of Snomed and archetypes in actual fact. So it's it's very nice that this conversation is starting, and I hope that it will continue. I was talking to Eric and Daniel yesterday when we were doing some planning around this, and I was pushing back and saying I think we need to keep the terminology binding quite simple, and it's mainly from the point of view of governance. All right, the clinical knowledge governance and what we have to do around the archetypes and the various versions of archetypes, and then translations of archetypes and so on. The governance process to manage that is huge, and people underestimate how much that is. When we start to add multiple terminologies potentially, the overheads of adding terminology and then maintaining it over time is also very powerful. So I'm talking about the bindings to identify a data element name or an archetype name. I'm not talking about the value sets. That to me is a no-brainer. We need value sets, absolutely. But it's how much, you saw some of the data element names, like systolic had a Snomed code with it. So I'm talking about those kinds of equivalents where you're trying to identify a name. And I know that when you start to try to move data between different formalisms, so between open-air archetypes and other equivalent kind of ways that data is implemented, Snomed and other codes are often very key to making sure that we've got equivalent data elements that we're matching. So there is certainly enormous need for this, but I think we need to tread gently and slowly and actually justify every decision that we make, because every time we put a coding into an archetype, we're building extra work for the people actually finding the right code, getting groups to agree that the code is actually the correct one for the place that it's been put, and then to actually maintain it as the archetype changes, as the terminology changes, and so on. So the overheads into the future are huge. So I think we need to investigate this and actually get our best bang for buck and understand if we bind something, we're doing it for a clear reason and we're going to get a benefit from it. Because there is a danger, and I do hear it in lots of places, that we should just put terminology binding and have Snomed codes on every data element, and it just sends shivers down my spine. I just dread it because I just think people don't understand what it actually means in practice into the future. So we need to find the sweet spot, all right, where we get the benefit from all.
So I have an example which is not exactly the same, but there has been work between IHTSTO and the committee that develops the LOINC laboratory terminology, which is not used in Sweden, but is used in Australia and the US and a bit of. And they're doing the mapping to Snomed CT has actually been helpful in identifying problems in that terminology. We're doing something, trying to do something similar with the MPU terminology, which is used in Sweden, Norway, and Denmark, where Sweden and Denmark are also Snomed CT countries. And we see that we actually could benefit from using the structure of Snomed to help maintain the MPU terminology in this case. So there, I don't have any, I don't have enough experience to talk about archetypes in this space, but at least for similar cases, there is actually an additional benefit, and the cost could be limited once you have the experience of doing this work. So it's an open issue, but I think we could dive more into this and see what comes out.
So it's a lot about what are you going to use those bindings for, and then you could add them, and then there's a benefit of there's a logical structure with computable things that you can check within Snomed that could be useful to find things. Another thing you should think of is what if we don't have something like shared information models and archetypes, and we just say, here we have the Swedish translation of Snomed CT. Now we throw it out over the country and start using it. That will be equivalent to everyone having unpublished archetypes, different in every EHR system. And then you put in Snomed codes, however you want to, everywhere. It's going to be very hard to really get the full power of Snomed CT out there. So actually getting good Snomed CT usage in the country without trying to coordinate at least some information models, I wonder how that would be done. But that discussion is not heard very often. Well, a little bit with national information structure, but then we have another possibly clashing issue. Is this actually useful at the clinical level? Do they understand the kind of modeling? Does it fulfill these detailed needs? We have some other questions here also. Let's get into some... There's one recurring how to do this in Sweden thing. We'll save that one a little bit. There's many people think, okay, what's the next step? What do we do? But how do you do at a clinic to go from paper-based documentation to a structured electronic documentation? If you're in that lucky situation or unlucky situation that you're at a paper level now and you have a green field, I'm going to jump into this electronic health record thing. What would you do?
I'll try to answer that. It's a really hard question, but I actually sometimes show a slide about how to get structured records, so I'll try to rephrase that. The first step, you need to have a system or a software product that can accept structured data. That's the first thing. Second, someone needs to make the information models. Third, you have to put the information models into the system. That's on a really easy, or very extremely simplified level, of course. But I think those are the three main steps that you need to perform. I can't really go into any more detail than that. I don't know anything about the situation.
I think the maybe most important is that the structure is the right structure, so the clinicians accept to document in the structure you have provided them with, and also that it is really easy and fast to find the correct structure, like the correct template for each situation, and also that the template adapt according to what you enters. For example, the example, they don't know who you that mentioned it, but if you say that no problem with a specific body part, then the system shouldn't continue to ask about more detail of that body part. Instead, it should just continue and really adapt to what you already have entered into your system.
I'll just add something. There's also some people have an idea that it's a good idea to use template to automatically generate user interfaces. I don't think that's a good idea at all. I think you need at least some way of restructuring the different elements or the fields in the user interface, and you definitely need something like you described to close things and open them, and choose which kinds of user interface widget each element should have, and so on. So don't try and auto-generate user interfaces from templates.
This is a kind of tricky fundamental question, and you can answer it at a number of levels, I think. Up until recently, the simple answer would be go and look up all of the vendors and see what they offer you and make your choice. And that's been the way we've bought electronic health records for 30 years. We've taken whatever the vendors have at the time and what they have perhaps consulted with, one or two in-house clinicians to think about workflow and data quality and so on, and that's what everyone has had to deal with. Now we are getting to a point where we are actually getting more choice with this kind of thing, but we have to find vendors that are willing to participate in this, and they're not necessarily out there at the moment. They're just starting to become wise, like some of the ones that are involved in the openEHR Foundation and so on, that there are other ways to do things. But there's still a lot out there who are saying, if you want interoperability, buy more of my system, all right, rather than looking at open data and the ability to share information. So what we need to do these days, I think, if we're starting to look at that transition, is actually to decide what we want. Do you want to buy an off-the-shelf product that will be effectively buy more of my system? Or do you want something where you have control of your data that you can shape in some way to actually be what you need for your patient care, for your interactions with other systems, for your reporting, for your research and so on? Because in that case, you need to look at your requirements for something like openEHR or an equivalent thing, with terminologies, and you need to go to the vendors and say, this is what we're looking for, and that's how you start to make that choice. So that's a slightly different spin, I guess, on how do you decide what to do. But it's actually a choice that we now are starting to get and potentially to be able to use into the future as the de facto way of buying an electronic health record. But it wasn't available until the last couple of years.
So I think that in this room here, there's a lot of people who have enormous experience of introducing electronic health records. So I see several people here who've worked several years doing just that. So just go to your own organization and look for the experience of the people working, making the templates, defining the keywords, and so on. And it might be that the tools that they were using were not as sophisticated as the ones that we have been presented with here. But I assume a lot of the processes will be very similar to specifying templates, checking the requirements of different clinicians, departments, and so on. So go ask the departments responsible for the electronic health record today, and see their experience and what they have to say.
I'm interested in this question myself also, because together with the emergency department here in Linköping, we're actually going to do that. They have a paper record for part of their things that need to happen really fast, where using the electronic health record system would kill the patients and things like that. So they want to go from paper, that little piece of paper, double-sided, to something electronically. We will do some experiments with that, try this open-EHR approach, and try to explore those things. So if you're interested in that, feel free to follow that project. We'll try to be as open as possible. We try to learn some things, see if this is useful or not. And also when it comes to auto-generating interfaces, it's true, you shouldn't just push the button and think that the interface you got is a great thing. But if you're a developer, it helps a lot that you can push a button, get an initial interface, and then you rearrange things and add a little bit of logic instead of trying to decipher all these strange things the clinicians say from the beginning. They've already said a lot of things when they made the archetypes and the templates, so this dialogue becomes a lot easier, and you have a very much easier start than starting from scratch.
Just one more quick comment. It's not necessarily a good idea to structure everything just because you can. Some things are best expressed in free text and should be kept that way. And the clinicians are the best people to decide which things to structure and which things to keep in free text. And you should generally have a good idea of what you're using the data for if you choose to structure something.
Part of the information that might be trickiest to structure is what has happened before, like what have the questions about previous diseases and previous treatments and those kind of thing. And if they are recorded in a structured way when they actually happened, then it might be unnecessary to ask the patients these questions about previous illnesses. So these parts of the EHR might not have a need to be structured because you don't need to ask the questions.
Okay. Now we have this little question here popping up in different ways. How can we get this organized and done at a national level in Sweden? I don't think we are the right people to answer this right now, but looking at Norway, I think is interesting. But which organization in Sweden that would be interested in it? That's a bit tricky to know. Do we have, you could raise your hands, those that are from Inera, for example. Not saying that, yes, we will take it, but that just as you know that they're here. Okay, we had some people, and we have from E-hälsomyndigheten also. They and Socialstyrelsen. So yeah, so we have these three that should be talking about this, and of course, it's hard to say that, oh, we should go for archetypes. They said, okay, we'll go for Snomed CT. That was an easier political choice or something, whatever. They took that choice, and that's nice. Regarding archetypes, no one dares to say anything about that right now. But we have all the Cambio customers that will get these archetypes into the system sooner or later, perhaps 2017 or something. We'll see it rolling out in clinics. We already have them in the clinical decision support module, but that's nothing that we can touch and change. But we'll have to deal with it ourselves in 2017 and onwards. And then should Cambio be the organization to deal with this archetypes and templates? Probably that's not a clever way of doing it. In Norway, they said, no, we want vendor-independent things so that people can reuse these things between systems, because we don't want to force everyone to use Cambio system. That's not the point of archetypes. The point is to having something neutral. Do we have any people in the audience or here that have any comments about how to continue in Sweden?
Just a general comment. I think, I think that if the Swedish regions that use Cambio do not get together and start a common governance of archetypes by, did you say 2017? Yes. When you can start using them in the actual production system, then I think you will find that you will have archetypes sprouting like wildflowers, like I mentioned in my talk earlier, and that will you will ruin a perfectly good chance of interoperability between those regions. And we're already seeing it happen in Norway, even though we have the governance. We're not quick enough. We should have started earlier to be able to have more archetypes published before DIPS is starting to use them in production. So I would advise the Cambio customer regions to get started as soon as possible. Even though 2017 seems a long way off, it takes a while to establish these things.
So starting with an education today is perhaps not a bad idea. We have two different comments here. I don't know, was one of them a follow-up on this one? Is this a follow-up on? Okay, let's start with this one.
Yeah, Göran Karlström again. Eric, actually you are way off time limit because two of the Cambio customers will start in April 2016. And so we are actually really in a hurry. And obviously, perhaps we could have the choice of seeing this as an appetizer and decline further eating it, or we would really love it and wish a full portion of it later. So that's the main question for us, and thus also our discussion of coming and visit you in Bergen and looking at the national governance.
So if you want to go on that trip, talk to him. Yeah.
My name is Per James, and I'm a politician here in Östergötland. As I understood it, in Norway, the factor to make it a national issue was that it started in Stavanger, right? Oh, somewhere. Bergen, thank you. And I think it's the same, it could become the same way here in Sweden, where even if it starts with a vendor, it would not make a very big difference. And also the ongoing work with the 3R collaboration would also be an extremely important factor for this.
Yes, I agree that whatever the 3R is, the three big regions in Sweden, whatever choice they make, I would say is very important. They should be clever about what they say when they want to buy systems, because one option is, of course, just pick a proprietary system and get 5 million people's records locked into a proprietary system. might not be the best way of doing it, but if you do it in a clever way, you can say, okay, we'll use the system, but make sure that you could at least export the data or share the data modeling somehow. But I think a lot of those people are in this room right now. I don't know if they're allowed to say anything about their thoughts on this question. Anybody? Not right now. But ask them in the restaurant or after a couple of beers or something. So I think I've heard that they've been thinking in interesting ways. Not necessarily open-air ways, but this mindset of having some kind of openness, I think, is taking hold. Let's see, did we have any other questions on this subject? How could you support this at, or did we have a, here's someone from 3R. Let's hurry over here.
I'm Helen Broberg from Region Skåne. So, I work in the informatics group in 3R, and I just can say that we are planning or discussions 3 informatic projects. And one is that we need an EHR model, an information model in higher level. The third is we need this infrastructure rules and guidelines for this. We use this. We need archetypes or clinical models. And when the third one is master data, we also see. And we don't see what we should do this our own. We see that we must do it together.
What's master data?
So that's very interesting. That we should do this together somehow in Sweden and in a practical way. I think we'll end there sooner or later. Just when we mentioned this picture, I think here you've seen some people, and we're nerding in on different circles, but still knowing a little bit about these things. I think you should think of this locally also in your organizations. You should have a team with people, give them chance to specialize in decision rules or in documentation models or in terminology systems. Some of them should be going to the Snomed CT course. Some of them should be getting deep into things like this, open-air or not open-air, whatever. Check what's out there, and some should go deeply into this and form teams. Try to think of that. Give them time to specialize and give them time to talk to each other. We can have really interesting discussions when you have a group like this. Okay, any other questions or comments from the audience right now?
Well, you already touched on it briefly, but could you comment a bit further on the compatibility between the national information structure and archetypes?
That is a very, very good question, because now we're talking about the National Board of Health that has a national information structure that is in 3 levels. You have a process model, and then you have in Swedish called a begreppsmodell, and then an information model. And when you go down to the information model, that's where we have, at least where I as an information architect in this region, am thinking of, I don't know if this will match or not. If I look at the begreppsmodell, they say in the middle, I can look at that, I can match, that's that part in open-air, and that would go to that part, and this would be an archetype, this would go in the reference model. If I had these legal requirements and stuff at that level, I could definitely map it in. When I look at the information model, I don't want to be rude or anything, but it's using a very old kind of modeling style that has been abandoned even by the organizations that invented it. So it could be that it works fine. Most likely there will be some issues, but no one has tested it, and that's the problem. It's okay to do a first thing. If we actually need this information level and have the demands at that low level, that could also be questioned. Maybe we could put them at the level above. But if we want that, then we really need to do this second step of, let's check, does it match with HL7 Fire things? Does it match with openEHR Archetype things? Or will we get into trouble because we are prescribing this exact way of doing information model, doing this and that? They often say that it's not IT, this is at a higher level, but actually when you get into information models, you're at the exact same levels there as like openEHR. Then openEHR is not IT either. So they're in the national, the information model in the national information structure is at the same level as Fire, openEHR, and these things, and they should start a project where you check, do these things, does this block using international things, or does it enable something? I think we definitely get enable that, okay, this shows that this paragraph in this law should be matching down here. That's useful. But if we have a problem that by prescribing this information model, you need to turn in your information based on this model, you might actually make it very hard for us to reuse international things. Or maybe with some tweaks, we could actually get it to work really well. But that has not been tested. There should be a project by someone testing these things and then feeding that back into the National Information Structure project and see, okay, we need to change this and that. It still fits the laws and everything. So you might get a situation where we in this region, for example, we can use these international models things, and we will follow every law and everything in the begreppsmodell, the medium thing. We will be doing things right according to that, but we will not be following the bottom part, the information model. Are we doing bad things then, or is this okay? That has also not been answered. So there's some questions that I have. There should be someone testing, trying these things. I don't know exactly which team doing these things, but it will be interesting. It should be started.
A few more comments on the same topic. My name is Erik Nissen. I'm working for Cambio Healthcare. I've been looking into the national infrastructure, NE, and two comments on it. The first is, if you count the number of clinical concepts, it's roughly 30 or 40, compared to the figures you have on Snomed CT or Archetypes. It's my conclusion there is it's on a very high abstraction level. The second comment is that they have done a very good job going through all the Swedish legislations and a lot of Swedish national systems to check that every information element mentioned in our laws, mentioned in statistical reporting systems that we are obligated to report to, that is covered. So I find it is a very useful checklist.
And I agree too. Used as a checklist, it's great. As an information model, we'll need to explore that. I think you had some interesting comments there.
Well, I'm not sure it's interesting or not. Erik Eriksson, it's the National Board of Health. I just wanted to say to your comment there that this project of testing it is coming. So there is a plan. I have to admit I don't know exactly how far it's come, but there's a plan to use one of the test beds that's available in Sweden to use the information modeling in NE with the different formats that you're mentioning. So just quickly.
That's wonderful. That's something that we've been asking for, so it's great. We have responsive things in Sweden. That's wonderful. Any other questions from the audience right now? Do you have any things that you think have been left that we should address? Little things, thoughts during the day? Anyone in the panel? Let's see, 16. Okay. So we're getting close to where we should we've gotten past that when we should let people go now when I look at the clock. So this is, it's good that you don't have any more questions. We will now end this first part. Some of you I know need to take off with trains. And then after this little break, now I don't think there's any fika out there, but you could probably get a little bit of something to drink or whatever. We will demonstrate a little bit deeper into this using template or archetyping tools. That is for those going the course tomorrow, this will be an introduction to that. And everyone that's curious and want to get a little bit of introduction to these tools can stay also. So let's take a little break, and let's 5:30 get back here and have a look at the tools. And thank you very much, those of you that need to leave.